Hello, good morning, everybody. Welcome to the 27th episode of the Health System Fix podcast. I have the pleasure of welcoming Dr. Luz Garcini today. She's a licensed psychologist, researcher, and advocate who studies the health needs of historically marginalized communities. Welcome, Dr. Garcini.
Good morning, Dr. Mishra. Thank you for opening this space to have these very important conversations right now.
Can you tell me a little bit about your early life growing up? Where did you grow up? What was that like for you?
Wow, thank you for asking that question. I always say that, people often ask me, so why should I keep going? Why should I keep doing this work? And I always say, ground yourself in your why. Why is it that you do it? And it comes from your life story often, right? From our lived experiences. So I am originally from Mexico. And I grew up in a very traditional Catholic environment. And I became pregnant at a very young age. So I became pregnant with my daughter, who is actually also a clinical child psychologist, at age 16. And then 2 years later, well, a year and a half later, I had my son. So I was a very young mother. And, as in a conservative society that didn't look very well. So I stopped school. So I did not finish high school and I got married. In that reality for a while, in terms of just becoming a housewife and just being at the house with very limited resources, it was really, really difficult. So in that thinking process, and also as a result of other events that happened, we ended up deciding to migrate to the United States because I had some family here. So we ended up coming for a temporary move, like many of our migrant communities that you think I'm just going to go for a little bit and then come back home, right? And here I am 45 years later or so. So when I came here to the United States, I did not speak English. I remember I came with $500, 2 suitcases, and 2 little kids. And the system and everything was overwhelming. Trying to learn how to navigate issues, trying to figure out what to do, how to do it. I started surrounding myself with other immigrants. And in listening to their stories, it helped me as a mirroring effect to learn about my own experience. So one of the things that I say that it's a blessing in this country, there's a lot of people who want to do good. So I found many angels along the way. I started cleaning houses. So I cleaned houses and offices for about 10 years before I went back to school. And then one of the mentors that I came across in one of the community organizations that was actually helped me with a lot of assistance, like food and caring, she said, why instead of cleaning houses, you don't come and volunteer with us? You speak Spanish. You can teach the parenting classes for the parents who are at risk of losing their children. And that was my first introduction to patient contact, to kind of psychology. And I fell in love with it because at the same time that I was trying to teach parenting classes, I was learning what was parenting myself. Kids don't come with instructions. So it opened my mind to growth, but it also opened my eyes to the need in the community that was about when you empower the community with knowledge, you can transform your lives and the lives of your family. So anyhow, one thing led to another. And then she says, I like how you think and I like what you do. Why don't you go to further your education? And I was like, does it require math? Because if it does, I can't do math. And she was like, no, it's okay. So I went to community college for another 8 years. I stay in remedial classes. I learn kind of English language. I continued to hold multiple jobs. And on Sundays, I remember I eventually got my GED in Spanish because I couldn't pass the English version. And that's how I ended up in the community college for many, many years, trying to get some credits. And I fell in love with learning. But most importantly, I found out that I have been so lucky in this position that I had a responsibility to give back and to tell the stories of people that were not as fortunate as I have been to enroll in this path. So that is my why and why I love the work that I do.
I appreciate you sharing that story. Somebody reminded me recently that, in health systems, our view of people we interact with is sometimes only in a place of need or they are not doing well, right? And we, in the health systems, typically we don't really look at the context of their lives and all the things, other things they're doing, which are incredible many times. So it's also good to hear there's a full range of stories out there. I worked along the US-Mexico border. That's where I've worked since I finished training. In my training, my goal was to go to an academic center, but I ended up in El Centro, Imperial County in California, a mile from the border. And I just fell in love with the community work. I interact a lot of people. The way you describe your entry into this country, that's who I see as my families and patients. What was that first few interactions that you had with the health system back then, which may have been good, bad, and how could a health system who in general is trying to do the right thing, how could they do better?
Yes. Thank you very much. That is such an important question. And it not only happened when I first came in, it happens up to this day when I interact with my doctors. So I come with a culture when we prioritize the relationships always. So our doctors, the pediatrician for my kids, were family friends. Were people that you know for years that has treated your family, that understand the context, that sometimes, I mean, you can just walk in and yes, you're going to wait for 3 hours right there. We also operate under a different time concept and system. But when you come in, you don't only go by what is your diagnosis. You're invested in learning about what is that context, because without understanding the context, any medical recommendations are not going to get that far if you cannot implement it, if you don't have the resources, or if you don't have that sense of building trust with your physician. So an approach, a holistic approach, was what I was missing in any encounter that I saw here. And then I had the privilege of teaching medical students at the University of Texas Health Science Center, San Antonio. And when I was teaching them and watching them in interactions with patients, I said, put your white coat on the shelf right now. What are you seeing as a person? And yes, I know, right, that physicians are overloaded with time constraint, but it doesn't take much time if you ask the right question and connect with the right person. So that connection, I would say, is going to save you in the long term so much time, because patients are going to be more likely to comply with whatever they need to do to stay healthy. Investing in, just like you mentioned, knowing who that person is, what is the context of their life, what are the barriers that are getting in the way for them to achieve the best version of themselves and for them to thrive. But most importantly, also, what are the facilitators, the resources that they have within their hands, the community assets that might be available so that they can be on the way to make this happen?
I see all ages, but in my child psychiatry role, which is what I did a lot, especially in Imperial County, very rural, primarily Latinx population, I spent probably half my time talking about the school system and what the rights of the parents were in the school system, which they did not know, and the school system often didn't want them to know, and educating them how to write their letter for an IEP and making sure their kid had the right support and language and all of those. And that education was not medical training, that was just separate. And as you talked about medical students, I think it's so critical. I tell medical students and residents, training makes you a doctor. It doesn't make you a good doctor.
Yes.
That's your journey. You have to you have to work on that outside of school. So you talked about your journey. What drew you to psychology and then research?
Well, psychology, I always say, is the connection to the soul. And it's a beautiful field that as you learn it, it allows you to grow yourself as a person. So in everything that I do up to this day, the imposter syndrome is so real. I learn from every interaction, from every collaborator, from every participant, from every student that I have. So it's never boring. It's always challenging, though. And it is a fascinating, right, that I do believe that this field allows you to embark in this process of the goal as to becoming a better person so that you can serve other people. So that has always been my motivation about the field. Challenging, sure enough. Do we have many things that we can do better? One of the things that I right now tell my students when I teach the psychopathology class is like, my generation and past generations have messed up a lot of things, but we didn't have a lot of guidance. We have to learn in the process. Our new generation is our hope, of physicians, of mental health providers, of social workers. how they can work together. The biggest piece that we need to understand is that you cannot wear all hats. But if we build integrated systems where people come, where you can pick up the phone and talk to the social worker and bring the behavioral specialist and bring the MD and bring the nurse and bring the community partners, bring the faith-based leaders for a lot of communities for that, they anchor on that, then we have a better chance of succeeding. So new healthcare models is what's going to keep pushing us forward.
Healthcare models that actually look at the full human, not just the full human patient, the full human frontline healthcare worker too. So you'll see a lot of times we're not even enabling our frontline people to do their best work. If the PCP does not have enough time, then are they going to give 5 minutes more to a patient with dementia and their family that they need? Or somebody who's in crisis? They may not be able to, even if they want to.
It's really hard, right? We need to keep our providers healthy. I mean, one of the saddest statistics that we have is the high suicide rates that we have in medical schools. And we don't talk about that. We need to protect those that are going to care for us, our nurses. And it is really hard. You know, I was very, very blessed to work in inpatient medical units where you see patients with cancer, with neurorehabilitation units, I mean, across the board. And I saw the amazing labor of love that they do every day under very difficult timelines and conditions. When they lose a patient, for them it's hard. And they have to keep going. They can't slow down. Building these systems that also allows for them to recharge, to rebuild, and to have those support systems that help them know that there are things that are beyond their control.
This reminds me, I was in my first year psychiatry residency in Detroit, and I was at the VA. So this is one of the first few patients I ever saw as a resident. We were in the inpatient. We developed a very solid plan, but this person has severe bipolar disorder, long family history of suicidal behaviors, all of that. And we discharged them. And then I know like a week later, one of our nurses just walks by and tells me, oh, this person died by suicide. And that's it. And that's how I learned about this happening. And that's the only discussion that was had about it, which is that somebody walked by and said this, and that's all. And to me, as a first year resident, it was a very disturbing time, which at that point, you sometimes in medical field, you feel that you are immune from all the problems that you're seeing in your patients. And it was very disturbing for a while. And I think I luckily had family in the area that helped me be okay. But we forget about the difficult situations you're dealing with every day.
And I think the most important people, thank you for sharing that story. It's so powerful because we forget how connecting with our human side, with our vulnerabilities, also help reduce that patient provider hierarchy that exists that kind of doesn't allow to level the plane. When we show our vulnerabilities to our patients, they start feeling like, okay, I can open who I am. You know, one of the biggest challenges that we have, and we see in this study over study in our immigrant communities, is because they're constantly hearing this rhetoric of these communities are a burden to society, it's really hard for someone to admit, I am struggling right now, right? Because that reinforces that voice that says you are a burden. So they're going to deny everything. Everything is great. Everything is perfect. Everything is fine. So when they come in a medical encounter and the physician or the psychiatrist or the psychologist starts asking something, you're going to find denial. You're going to have a very surface level, yeah, I need help, but I got this. If you level the plane and you show I'm vulnerable too, then you're opening the doors for those conversations to happen.
I've been thinking about how trust is built, and it could be between anybody. It could be an executive and a clinician. It could be patient and provider. It could be organizations. I think trust is not built on anymore, at least. It's not built on showing 100% everything is perfect. If somebody says everything is perfect and there's no nuance to it, it is just difficult for me to trust that. I think you need to show vulnerability. You need to show things are imperfect. And we are still working on getting it better. And even in my leadership roles, I found that when I open up about that, people have more trust and confidence and are willing to, my team is more willing to go with me on this unknown journey than when I say, oh, everything's perfect, don't worry about it. So that's not acceptable anymore, I think, in our workplace.
Yeah, such an important point that you're making, right? That comes with the vulnerability. But the other piece that we do a lot in medicine and in psychology and psychiatry too is we're looking for what's wrong, right? That's where we start our conversations. We don't look for what's right. When you start building that and reminded people that they have already survived 100% of the adversity in their life, and that makes them strong and beautifully made to withstand anything that comes their way. So if we start planting that in our patients, they know that despite the vulnerability that they're open up, they can cope with anything, and that you as a provider perceive them as a strong person, capable and empowered to take care of their health. That transformed the entire clinical encounter. And you can do that in 2 minutes.
Yeah. And the fact is also, if you do not empower this, or at least remind them that they have the power, it's not even empowering, it's actually just reminding. The fact is that you can only do 50% of the work anyway, at best. I think even 50 is high. So if you don't have an empowered person with power there partnering with you, they're not going to get better. You're not going to get to the outcomes that you're thinking.
Absolutely. And investing our time to ask our patients, right? Just get feedback from them in terms of how are we doing as a provider? Do you have everything that you need from me today? What else could I bring to the table so that you can do what you need to do to take care of yourself? We might not have all the answers. Maybe we can point them in the right direction, but if we don't, it's okay to say, I don't know right now, but let me get back to you.
And actually, to me, I did my medical school in India and I grew up, I was about 26 when I immigrated. In India, the culture was, at that time at least, it's changed a lot now, but culture was the doctor needs to know. And so you had to sometimes pretend to know, which is not right, but that's what the expectation was. In the US, it was nicer to see that you can actually partner and say, I don't know, I'm going to find out. I've seen it in your research, there are three terms which you use: biobehavioral, sociocultural, and socio-ecological. If you can briefly break down each of these, and maybe from a clinical lens, how does a clinician think of these concepts? Let's say biobehavioral. What does that mean when you're talking about a patient?
Well, it is the connection, right, between everything that we do, everything that we are, affects physiologically how we function. Every cognition, every thought has a link to a biological, whether it's hormones, whether it's neurotransmitters. So we need to look at what's happening holistically. That is the connection that we always need to do. And part of psychoeducation is helping people understand how stress, how experiences, how new knowledge gets under the skin to increase or reduce a risk for chronic diseases, even to acute diseases. Even our immune systems fluctuate depending on how our mind and our body is doing and the situations that we encounter. And then also at the point when we have heard a lot about brain health, and everything, depending on the context that we live in, how we absorb those experiences, and what are the voices telling us in our head every day, what we put in is going to affect our mind and is going to influence our ability to function in our everyday lives. The things that we do, how we perform our work, which is all connected to the brain, to the cardiovascular system, to the respiratory system. It is all connected. So the more we can learn to understand our body, in those interactions, the more we can engage in our own self-monitoring process. I mean, this is not new science. This is something that Asian cultures have done for millenniums, right? For thousands of years. Mindfulness, why don't we open our eyes to that? That is wisdom. And it doesn't cost us more to be able to develop these things.
Your own self-awareness of your body and mind state is just goes such a long way. So let's talk about socio-cultural. How do you think about that concept?
Yes. Oh, wow. Well, we're embedded with social beings by nature. People often talk about cultural sensitivity, and I believe absolutely is very important. The beliefs, the practices, the cultures, the values that we come from, but people often forget the context And the context is also very different. Sometimes it might have to do with your culture, but sometimes it doesn't. The context talk about the neighborhoods that we live in, the infrastructure that we have access to. One easy one and clear one is transportation systems. We can develop, to give you an example, we can develop food RX programs and place them and give people vouchers. But if people don't have a way to carry the food to go get it on everyday life, they're not going to use it. We've seen that over and over. So we're wasting resources that could be magnified if we understand how the context and how the culture come together to influence what a person can do, not that they choose to do, because sometimes it's beyond their choice, right? What they can do to take care of their health. So that is the importance of us as providers to think in multiple levels, to think about the culture, but also to think about the context and how those influence who we are psychologically, the thoughts that we put in our mind, the things that we carry in our heart, and how all that together influence our biology.
Fact is that in many situations, those factors are way more important than any diagnosis that I can give them.
Yeah, absolutely.
And this, like, the last term, socio-ecological. What does that mean, and how do you think about that?
So that is so important if we're ever going to talk about how do we hear all the time, less systems restructuring and we need systems intervention. What that means is that we need to understand what's happening at the individual level. Each person, what are the challenges, the barriers, and the facilitators to their health? What happens at the interpersonal level? What are those connections that that person has access, including the patient-provider interactions, and how that it is embedded in a community context of access to resources and access to sources of information that are out there that also feed into the culture and the context of the person. But we cannot forget that at the same time, those communities are embedded in an infrastructure that is guided by policy that we need to think about. So when we say, well, people ask me all the time, all of my work is somewhat linked to policy. Well, how can I do policy? And people feel like, even our providers feel like they're too removed from policy because they think policy only happens at the state level or at the city level, or that it only happens in Washington, D.C., the big one that is going to change the systems. And I said, no, you make policy every day. You bring the basis for a case that could be used if we put it in the right hands of our legislators, right, or of our officials. You make policy within our institutions. The minute you bring up an issue that you see, I'm going to give you an example in prior healthcare institutions that I have used when there were policies. These were all older policies that people could not wear hats or anything in their heads in med school. Well, we have a lot of different cultures that have to cover, if we want to be respectful of religious variances or even of certain cultural issues. Or African American girls have to sometimes cover their hairs. And that was an easy policy that could be changed just by contextualizing and understanding what it means. And that's how we change, building inclusive spaces for people, joining boards of our community organizations to talk about what are some of the things that we see at the community level so that eventually we're changing how the organizations work. And eventually, the bigger we become, it raises the level to the policy. So that is the socio-ecological framework that we need to think about when we see something.
The very interesting piece of that, what you just said, is the same organizations that are advocating for better policies at state or federal levels sometimes have restrictive policies within their doors. I've been involved in creating policies. Even while initially you want to do good work, the policy eventually becomes something that restricts access and like eliminates people. And then you think, oh, my goal was to actually include people, but this is the way it is structured is actually excluding people. Yeah. I want to tell you about a kind of a little bit of work I did. In 2021, we had kids were getting separated from families, really traumatic time. In San Diego, we had about 3,500 kids housed in the convention center. And I was just lucky that our organization was asked to see if we can do the mental health services. I was the chief behavioral health officer at San Isidro Health in San Diego. So I got to kind of oversee mental health implementation for 3,500 kids. And it was just from I would say, professional and just learning perspective, it was just an incredible experience to be able to say, we obviously said yes and we would do it. But what I found really, I don't know if it's surprising, but I found consistently was it's all minors, right? Some of these kids had been through very difficult traumas within their home country and their journey to the US. And then they were met with Border Patrol and ICE, and they had reached that point at the US Mexico border with expectation of a land which has opportunity and is welcoming, right? And then they met this sudden removal from family and placement in places, and then now they're housed in a convention center with 3,500 kids. And if you look on paper, the traumas they went through in their home country on the journey, sexual trauma, physical trauma, gun violence, all of that, on paper those were maybe more traumatic, but in that moment, that jarring effect of separation from family was definitely the biggest thing they were stressed about. And we did the best we could. In 3 months, we created treatment plans for some people. We actually sent pages of recommendations, and we hope that lands in the hands of somebody who cares. How do you think about how they presented and what that experience was like for them?
Wow, thank you so much for sharing that story. And now, when I think back, you and I were doing the exact same work. I wish we could have met before to do that, because it was also at that time that I was at the University of Texas Health Science Center in San Antonio, and the Department of Pediatrics reached out to me and they say, we have a shelter with 5,000 kids and we need to do something. They were all boys. And they were between the ages of 7 and 17. And they say, we need to go because the staff reporting really, really high rates of trauma. And my first thing is that I said to them is like, you can't treat trauma while you're embedded in the context of trauma. So give me 2 days and I'll come up with something. So I put a tremendous amount of volunteers. My med students jump on board, and I was like, switch your hats because you're going to be psychologists today. And we developed booklets, 2 very simple booklets that were about empowerment, that talk about migration. Because the other thing that I saw from some of the people that were already there, trying to do good work, but you don't open when the patient is bleeding. So, and one of the things that I realized also, they came because they didn't understand the context of migration with a very condescending attitude. And these little men, even the ones that were 7 years old, would see as the strong men that migrated, they were unaccompanied minors, to save their families, to save and go back there. So you cannot treat them as a kid. You cannot approach them in that sense because they have lived much more than we probably have in our lifetime. So the booklets, they're called the Bridges, the Puentes booklets, were very empowering. It was about who you are, starting to think about what is it that you're experiencing right now, physically, emotionally, mentally. A lot of them feeling themselves as mini superheroes. And it was a moment for us to keep them strong amid adversity.
Right.
That was the first booklet. What we found out is obviously we did not have enough people to do it one-on-one. So we printed, the medical school was so kind that they printed them for us at no cost. What we noticed is that one of them will grab a booklet and go sit down with 10 of them. And they started building within themselves peer support groups.
Yeah.
And all of a sudden, all we had to do was walking around to see how they were talking about the content that was delivered to them. So oftentimes we feel like we need to do it all, but they bring the wisdom within them. And we just need to facilitate the resources and the space for them to tell their story. At that point, the most important thing, and I would say this in all of my studies, the most important thing is to allow people to tell the story. And if we go back to Carl Rogers, who was a genius in the humanistic approach to psychology and to life, is unconditional positive regard. If we can give them that. We talk about the plans. What were their plans in the US? Some of them were going to be reunited with their families, which led to booklet 2, right? How do we deal with those encounters when they were sometimes fathers who didn't know their kid? They left long time ago, or they were going to be placed in foster home, and what that encounter was like, to start thinking about what was life in the United States. And what we found out is a lot of them came with the mentality, I'm going to work. I'm not going to go to the school. So imagine what is the different reality here when it's illegal for these kids to work? And we had to switch them to, you're going to have to go to school, and we're going to embed it in a school system when they already come with a lifelong history that is more like an older adult who have endured a life of trauma, that knows how to survive. And they're going to have to learn in a different language with different people. It is really hard, but I think we need to think of different ways of delivering the resources to this community so that we can ensure that they can thrive.
Yeah, again, I feel the same, that I wish we had connected back then, because my experience, I would say, in many ways is so similar. It was a very formative experience for me as a clinician and as an administrator, and just because I got to do things differently than we would have to do within the health center. No, so you can get creative. And first few days, we actually implemented, we were doing groups with therapists, but we realized that is not needed. We're not going to delve into the full trauma today. We're going to manage anxiety, and we're going to manage uncertainty tolerance, because we don't know when somebody's getting reunited. So we quickly, within 2 or 3 days, we went to groups where we got our case managers, watch one, do one, and then keep going. They were way better than our therapists and psychiatrists, because they were connecting at a very human level, and they were doing the support. And then we had psychologists, therapists, and psychiatrists available for, somebody who's severely ill or psychotic or suicidal. We were running 4 groups a day with 30 kids each. We were reaching over 100 kids a day, like 800 kids a week. And the word spread, they enjoyed the groups and they felt supported. The other thing, what he also said, I noticed that a lot of the caregivers in the spaces were not trained in healthcare, were new. So they were, why is this person irritable or not happy with what I'm doing when I'm trying to help them? So I created a lecture for the support givers. That education to the caregivers actually dropped the number of panic attacks referrals we would get every day. So I agree that if it would have been nice for us to just brainstorm together.
Yeah, it would have been fantastic. And your comment just reminded me also that if we really let go of our own ways of doing things, our own fixations. At that time, we were working with the Department of Health and Health and Human Services, actually, and they were very open to our recommendations, because you're right, they had no idea what they were doing, and we worked really well as a team. And it was just really basic for us to listen to the kids. Some of these kids had been in that shelter almost for like a year now, and they had no light. So what they were saying is, can we go somewhere where we can see the out? It was an easy recommendation for us to give to Health and Human Services so that they can implement something that will help the kids feel better. The other one is the kids were saying, well, we hear there is a buzzing alarm that sounds at 6 in the morning for all of us to wake up. And it was a trigger. It served as a trigger. So we started saying, okay, what would you like instead of that? Can they just start playing sounds of nature, like birds, that connect them to the places where they came from? Because a lot of them grew up in el campo, and outdoors. And it's the same effect, it's just nicer. And these kids are going nowhere. They're stuck in these walls forever. Why do you have to wake them up at 6 a.m.? Can't you just push the alarm to 8? And they started thinking, and they were very receptive to our comments. So in something like that, you can reduce the risk of re-traumatizing someone else, even if it's within the context of the hardship and the restrictions that the policy brings.
Yeah, I agree. I had a very positive experience working with ORR, ACF, and SAMHSA officials. It was really very collaborative, and they were very open. So it was a pleasure to actually see so many federal and local agencies trying to do this together. So let me ask what's happening today, right? With our ICE enforcements and what it's doing in California and I know around the country, is for a lot of people who maybe have been getting healthcare within community healthcare spaces where they felt safer to go. Now they are feeling less safe to go there. I'm an optimist, so I know that this should end and will end. But when it does end, that doesn't mean the trauma or the fear of it ends at the same time. What should health systems, providers do to re-engage this population who may be traumatized and scared and like don't want to be counted? What can health system do to bring people back into the fold of healthcare?
Thank you. That is such an important question. And your message of hope, I think, anchors in what keeps our community strong. I think The most important piece that we need to do when we encounter people, whether it's now or in the future, is to acknowledge what's happening. The worst thing that we can do is to pretend like things are not happening, because it's that acknowledgement that we need to begin, so the people feel that you know where you are. You see what's happening. That brings again the plain level to a level of understanding. We need to respect people's ability to connect or to contact or to communicate with providers. But we also need to remind our patients that they are the most important thing for us at the moment, and they need to take care of themselves, because the system, we as a community, need them. And then respect whatever else happens in that space. Respect different timelines. People are going to have trouble trusting, and asking people also what are some preferred ways for them to engage in healthcare. We're doing that. So we are very privileged at the Center for Community and Public Health at the Kinder Institute to have we partner with over 70 community organizations, the majority of them safety net providers for the communities. And we constantly ask, how do people want to be delivered their information? What are their preferred pathways? We're dealing right now with, they don't want to use the portals. You're afraid of what the portal is going to say. Is whatever information I put in there going to compromise my ability to get insurance in the future? Or can someone look at my records? So what is the information that we need to do? So at some point, I do believe that as providers, we need to inform our patients' rights. We need to let them know of their rights before the encounter. Any documentation that we can give them, any linking also, the way to build trust is often linking them to the resources that they need. I'm talking about food security, housing security, legal rights. I think as our organizations, we have a responsibility to have a list of those available providers with sliding scale fees that are not going to victimize them, because there is a lot also of fraud that they are victims of. So if we become those trusted organizations that they know, okay, this is the list that the center is giving me for me to address all these other psychosocial needs that I have in my community, I do believe that we can maintain and grow that trust now and moving forward.
And what you said, maybe lead with addressing the psychosocial needs first before trying to fix an illness,
Yes,
right? That
absolutely.
will build that trust.
The bottom line that we see on every single study, and Maslow, he was so wise in his hierarchy of needs. If people don't have food in the table to feed themselves and their families, and I'm talking oftentimes parents go hungry, the child will not hungry, but the parents are struggling. So if we don't cover the basic needs, they don't care about going for screening. They don't care about going for mental health treatment. What these communities are asking is food, shelter, and jobs, because I am not a burden to the system.
Safety, yeah, lack of fear in everything.
But the most important is food. We have to think of the pyramid. It's really, really mind-blowing when you think we are at that level.
Yeah. It's so important to also remember I would do the exact same thing for myself and my family if I was in that position. And I'm just lucky that I'm not in that position. And sometimes people forget because they've not had that experience that it could happen to anybody. So we forget that, oh, these people are human, just like I'm the same human, just my resources and access is different today.
We got lucky, right? You and I both are immigrants. We both came in with difficult, challenging circumstances. We both have to learn to navigate this system, but we got privilege. And I think a lot of the times we forget. And with that comes to the table, okay, what do I need to do? And then invite other people. If we're already doing something like you, right? You're building this opportunity to talk about these difficult issues. You're doing your part. Then we need to ask other people, what are you going to do? What are you going to do with the platform that you can, so that we can ensure that we're using our privilege to help those that have yet to get the same opportunity?
I'm sure you've talked to healthcare workers who are just disheartened and I feel like I've been lucky that when I see a major problem, my brain just works better for some reason. So I see opportunity and solution. But I know that there are a lot of people impacted by just feeling overwhelmed that the work they've been doing for decades maybe is now just being ripped apart. What do you tell people to keep hope and keep going?
Yeah, I anchored in basically the message of every challenge brings with it with an opportunity if we approach the challenge as a way to develop competencies. However, in order to get there, everybody needs to take a step back. So if you're feeling disheartened, how are you taking care of yourself? Self-care is at the top. When you take care of yourself, your mind resets. And then you start seeing the opportunity in the challenge. So this, I learned it from my immigrant communities. They do it every single day. That is their basic survival. When life put them through their knees, is how they get up. They do it and they keep going. So I think we need to reframe that for us in terms of what do I need today to step back, take care of myself, whatever that looks like. It might be take a leave of absence. It might be taking a less heavy workload, but then I come back. When I come back, I start thinking, what is the challenge? What is the opportunity that comes with this challenge? Because that's how systems have changed. If we look back at history, that's how things have evolved by the difficult conditions that bring great leaders, that eventually people have rights to vote, that eventually people enjoy freedom, that eventually people have plans and access to resources. So I think we need to keep moving forward.
Right. So I know the Latinx population is very broad and not homogeneous. Even with unaccompanied minors, we had kids who spoke only an indigenous language, no Spanish even. So it was really varied. If you think about urban Latinx populations versus rural Latinx populations, from a health system perspective, what is that difference that people should know or consider when you're addressing the needs?
Yeah, that's actually a really good question, and it depends. It depends on where you're located. We know that there are many rural communities that act as ethnic enclaves, so then it becomes very safe. But at the same time, if you go in there, it's almost like you're in your country. Everybody speaks Spanish, everybody, all your food is there, and you feel very protected. You feel very supported. Within the current context, it can be challenging who can come and knock in your door. But it's a different system. When you move to the urban space, there is more competition. You need to start blending into the melting pot. You start developing other competencies just in itself, the ability to having to learn language to defend yourself, to survive. You're competing also for jobs with other people. So you start developing certain skills, or you start your willingness to engage in more risky jobs that are also going to threat your health. So they are different, but it also changes by geographical region.
And also, it was in Imperial County rural by US standards, but it has a Walmart and Costco and everything there. So I was telling my family in India, I work in a village or rural area in the US, but that's not the same as a rural area in India. It's a very different rural area. Yeah.
Oh, absolutely, right? There's rural and rural. If they want to see rural, we take them back to our country.
Exactly. Yeah. So recently I'm trying to do a deep dive in understanding the dementia care space. I know you have a talk coming up soon. What I'm trying to work on is understanding what's a good clinical care model in the dementia. And right now I see very few really good ones. It's very fragmented. Experiences for families and patients are not great in many settings. It's also frustrating for the care team. So my area of expertise and interest is really building systems that can support that. If I or anybody is trying to build a dementia care model of care for Latinx population especially, what are some of the things they should consider? What are some of the strengths or areas of need there that you're seeing?
Thank you so much for that question. People are going to say, well, Luz, what is it that you do? Because I'm also working in the dementia space across multiple levels, not only with the Latino community, but also with the Latino community with intellectual and developmental disabilities. So it adds different layers, right? But one of the things that we do here at the Center for Community and Public Health at the Kinder Institute is our agenda is driven by the community. Whatever they want, we're going to figure out how to bring the expert. We're going to make it work, and we're going to come up to try to answer some of the questions. So to that question in terms of dementia, what we found out is We were at the basic level in the community of information. And how do we deliver information that the community doesn't want to hear? Because we're afraid, right? A lot of people start in the community from the data that we got, start seeing Alzheimer's disease as a mental illness. And in the Latino community, same in the Indian community, right? Mental illness, we don't talk about that.
Yeah.
Even mental health, no, it has a mental label in there. We don't talk about that. We're okay talking about stress, but not about mental health. So the minute that's equated to the community doesn't want to talk about that. So what we ended up doing, and this is actually a project that is funded by the National Institutes of Aging. We are starting, I think, our third year and moving forward, is we develop a telenovela. So we develop a telenovela, right? We're going to be, it's starting to roll now, but we're going to be screening it at the Houston Health Museum next month, also for the community. In Spanish, it's available in English and in Spanish. That is called about Recuerdos de mi abuelo, memories from my grandfather, to start giving the people the resources that they need in an easy to understand. The actors are people from the community that talk about it. And after that, linking them to an opportunity for screening. But we need to find out also the missing piece that is coming after that is once people know whether they have the risk, because we're also building a biorepository of markers. Once people know they have the risk, or once people start showing signs, what is the family going to do, right? We know that first of all, is very expensive to have access to resources and treatment. Are we ready to provide them? Do we have enough providers? That is the other one. We don't have enough providers trained to be able to do that. And also our measures are in the dinosaur ages. It's very different to assess it. So we need to work on the assessments and the screenings. We also need to know on the pathways as to what does this, a plan for a family who might be in the initial stages, looks like in terms of housing, and how do we deal with this on a culture that doesn't believe in assisted care facilities. We believe that we have the responsibility to care for our parents, for our elders, is part of our culture. So how we do that within a culture that we need to keep working, we need to keep producing, and oftentimes our older parents or our older relatives are the caregivers to the next generation that comes in. So they're a crucial part of the family system. So understanding the family system within the delivery of that information and with a path forward, we need to figure out what that path is before we open the gates of diagnosing and assessment.
Now, by the way, the telenovela is such an amazing out of the box solution. I think it would work in India also. It's so interesting. I'll tell you, like COVID was first starting. I had patients who all range of diagnostic kind of severity, like from severe schizophrenia to mild anxiety. And I was really worried about patients who have severe illness because their access to care may be impacted. And towards the end, what I realized that the diagnosis did not matter how somebody did. What mattered was the amount of support they had. So a person who had mild anxiety, who's living alone, does not have much social support, did worse than the person with severe schizophrenia, but they're living at home with family.
And perhaps this is where we need to revisit non-traditional sources of service delivery. How do we build promotora programs that can assist these families to keep their loved ones nearby, to keep their loved ones at home, but that still they can get that care to assist the transition? We need to rethink our systems.
Oh, absolutely. I don't even want to say rebuild. I want to say we need to build the right systems, because I think rebuild, fixing, we've been trying so many things to keep things. I don't know if it can be really fixed. It needs to be built new, not even rebuild. I have a couple last questions for you. Your journey is incredible. How did you keep yourself ready to meet that next challenge that I know you wanted too?
Oh, very good question. I surround myself by very good people. And I think I honor the fact that I don't need to know it all, but that there's many people around that I can collaborate with. So I take it with humility because I'm also getting older, so I need to take care of myself. And I listen. I listen and I learn I also spend a lot of time with self-care. I have 3 dogs that are just amazing. I have a really good family, a really, really great partner, really good kids. So I think going back to those things that allows me to recharge. And I fall in love with learning. Everything is an opportunity to learn. But I also know that I don't need to know it all. And sitting in comfort with that releases a lot of the pressure of having to develop new skills. I also approach everything as a team approach, even with my team. My team keeps growing and growing. Our collaborations with the community partners keep growing and growing. And people say, how do you do it all? Well, because I'm not the expert. People come to the table, and if we're going to solve something, we sit down in the rooms in our community advisory boards, and we just say, what are we going to do? What are you best at? What can you lead in that space? So is what is called shared leadership. It comes from a collectivistic culture, collectivistic approach, and has always worked beautifully for me.
Yeah. It's also, I think, at some point, your job as a leader becomes, let's get all the barriers out of my team's way so they can fulfill their vision and idea. And let's help them fail in a safe way so I can keep helping them grow. So I think what you said, it definitely relate to that, and try to do some of that. Last question, what is the most exciting and challenging problem you're working on today?
Food security. Food security, because that's what we've been hearing in our community. We recently produced a report that the Houston Metroplex is one of the largest in the country and is one of the most diverse. Yet our numbers, we found out that a third of households in our urban region are living with food insecurity, the lack of access to nutritious and sufficient food. And that is linked to all sorts of health outcomes. So my goal is not to stay only at identifying a problem, is what are you going to do about that, right? Because I am accountable. If I see a problem, I'm like you. If I see a problem, I have to do something about it. We work under crisis. So now how do we start bringing or creating a coalition, bringing city officials, bringing the partners that we have, bringing retailers to come to the table and said, what are we going to do? We know the areas, we know the communities, we know the people who's most affected. You will not be surprised, Latino and African American communities and Asian communities too. What are we going to do about that? So that is the piece in finding the funding to make it happen. Because we know that that the approach of giving people food doesn't solve anything. So in the current context, when a lot of the community agencies that are trying to do the work are losing funding, how do we keep moving forward? That is keeping me up at night.
And, if you're up, I know it'll get solved. So, again, Dr. Garcia, this has been an incredible conversation. I appreciate you taking the time and talking to us today. I really hope people hear this, and it's going to be a message of hope for people who are in the field and sometimes feeling really overwhelmed.
Thank you, Dr. Mishra. Thank you for your time. Please keep doing the work that you're doing. I think it's so important to send this message, to educate the media. Also, I always say the media has a huge role to play in the information that gets to people. So thank you for the work that you do. And let me know if you're ever visiting in Houston. I would love to have you here and share with you a little bit more about what we do. In San Diego is close to my heart. That's where I went to graduate school. Work with San Isidro people. I work with Sushi Ayala. And with Dr. Talavera.
Thank you so much, Dr. Garcia.
Gracias.